Welcome to our deep dive, and today we're tackling something you face all the time as a medical microbiologist: sepsis in adults.
A topic that never really goes away, does it?
No, it definitely doesn't. And to guide us, we're focusing on Chapter 24 of the World Health Organization's AWARE book. That's Access, Watch, Reserve, by the way.
Oh, yeah. That's become like the go-to for antibiotic guidance, especially with antimicrobial resistance becoming such a huge concern these days.
Absolutely. It's like a roadmap for navigating that minefield.
A roadmap that's constantly being updated, too, because those bugs aren't standing still.
Exactly. But even with all the advances in how we treat sepsis, it's still a major issue.
It really is. I mean, when you look at those numbers from 2017, 11 million deaths globally. That's just...
It's a stark reminder of what we're dealing with, for sure. But before we jump into the nitty-gritty, let's make sure we're all on the same page about what sepsis actually is.
Right, because it's a bit of a shapeshifter, isn't it? The definition has evolved over time.
It has. Like, remember, severe sepsis. We don't really use that term anymore.
No, because the thinking now is that any sepsis is severe enough to cause organ dysfunction.
And that's the heart of the Sepsis 3 definition, right? It's not just about the infection itself.
Exactly. It's how your body reacts to that infection that pushes it into sepsis territory. Your own immune system, basically, going into overdrive and causing damage.
So we're talking organ damage. That's the key.
Yep. That's what sets it apart from just a regular infection.
And this is where something like the QSOFA score comes in handy, right?
Especially in those initial assessments. It gives you a quick snapshot of how the patient is doing. You're probably using it all the time already.
Oh, absolutely. But thinking specifically about sepsis, how has using QSOFA changed your approach, if at all? For me, it's become second nature to check those 3 parameters: breathing rate, mental status, and blood pressure. Like right alongside the other vital signs. It helps me flag those patients who might need a closer look.
Even if they don't seem that sick at first glance.
Exactly. Because sometimes those early signs of sepsis can be pretty subtle.
Speaking of subtle signs, that brings us to the clinical presentation of sepsis. What are some of those red flags that make you think, this could be more than a simple infection?
It's funny you should say that, because the thing that always gets me is how non-specific those early symptoms can be. You know, you see a patient with a fever, maybe chills, a rapid heart rate.
And those could point to so many different things.
Exactly. So it's like, how do you pick out the sepsis cases from the crowd?
Well, then you start looking for those other clues, things like confusion, low blood pressure, maybe a decrease in urine output.
Right, right. But even then, it can be a tough call.
It definitely can. You're relying on your clinical judgment, your experience, and a little bit of intuition, I think.
Oh, absolutely. And as a microbiologist, I always feel this extra pressure to find the culprit, the bug that's causing all this trouble.
To pin down the source of the infection.
Exactly. Because once you know what you're dealing with, you can start targeting the treatment.
And that's where those lab tests become so important, right? They help us fill in those gaps and make those crucial decisions.
Oh, 100%.
Yeah.
So you've got your microbiology tests, which are like our bread and butter.
Blood cultures, sputum samples, urine cultures.
Yeah.
Depends on where you think the infection's coming from.
Yep, exactly. But then you've got those other lab tests that give you a bigger picture of what's happening inside the body.
Like, how much organ damage is there? How's the patient's immune system coping?
Okay, so before we go down that rabbit hole of other tests, let's stay with microbiology for a minute. I know you've seen it all in the lab. What are some things that make those microbiology tests tricky in sepsis cases?
One thing that always makes me pause is when a patient's already been on antibiotics before they even come to the hospital.
Oh, yeah, that can really throw a wrench in things.
It can. It can make those cultures less reliable, Like, you might not find the true culprit because it's been suppressed by the antibiotics. Makes it harder to get a clear picture. It really highlights how important it is to know about a patient's antibiotic history, right?
Absolutely. It can completely change how you interpret those results.
So let's talk about those other lab tests now, the ones that give you that broader perspective. What are you looking at there?
Well, you've got the usual suspects for checking how the organs are doing: creatinine for kidney function, bilirubin for the liver, blood gases to see how well the patient is breathing, and if their body's pH is off.
Right, the basics.
And then there's CRP and procalcitonin.
Ah, yes. Those are the markers that can help us figure out if it's a bacterial infection or something else, and maybe even guide when it's safe to stop antibiotics.
They can be really helpful, but you have to be careful with them.
Oh, absolutely. They're not perfect.
I've seen cases where those markers were normal,
Yeah.
but the patient was still in the early stages of sepsis. So you can't just rely on those numbers alone.
You always have to consider the whole picture, right? The clinical signs, the patient's history, and those lab results.
Exactly. It's about connecting the dots. Okay, so we've talked about lab tests, but what about imaging? When do you find yourself saying, okay, we need a chest x-ray, or let's get an abdominal CT scan for a patient with suspected sepsis? Imaging becomes super important when you're not sure where the infection is hiding. If the patient's got those classic sepsis symptoms, but it's not clear where it's coming from.
Then you need a little help to see what's going on inside.
Exactly. Like a chest x-ray can rule out pneumonia, or an abdominal CT can show if there's an abscess brewing somewhere.
And ultrasound's becoming more and more popular for these kinds of assessments, too.
Oh yeah, especially in places where resources might be limited.
It's portable, easy to use, and it can give you a lot of valuable information.
All right, so we've talked about recognizing sepsis and trying to pinpoint where it's coming from. But now let's get to the heart of the matter.
Treatment.
Because at the end of the day, that's what it's all about, right?
Yeah.
Saving lives.
Absolutely. And we know that every minute counts when it comes to sepsis. We can't afford to wait around. You need to hit it hard and fast.
But as microbiologists, we also have this responsibility to choose the right antibiotics, especially with the whole antimicrobial resistance crisis looming over us.
It's like walking a tightrope, isn't it? You want to cover all your bases, but you don't want to overuse those big guns and make the problem worse.
Exactly. So how do you approach that initial decision, when you suspect sepsis, but you're still waiting for those culture results?
It's about making those empiric antibiotic choices. And that's where Chapter 24 of the Aware book comes in really handy.
Like a cheat sheet for sepsis.
Kind of. It lays out those recommendations based on the likely source of the infection and the resistance patterns in your area.
So walk me through your thought process. What are the top things you consider when you're choosing those initial antibiotics? Well, first off, I need to figure out where the infection's coming from. Is it pneumonia? A UTI? Something else? That helps me narrow down the list of potential bad guys.
Makes sense. You don't want to be throwing darts in the dark.
Nope. And then you've got to factor in those local resistance patterns.
Right, because what works in one hospital might be totally useless in another.
It's a local game, for sure.
Yeah.
You need to know your enemy.
So what about those really tough cases? Like when you suspect a resistant organism, one of those ESBLs, for example, but the culture results are still pending. How do you balance that urgency with the need to use antibiotics responsibly?
That's the million-dollar question, right? For me, it often comes down to having a good relationship with the infectious disease team. We talk it through, consider the patient's overall health, and try to make the best decision together.
That teamwork is so important. You can't do it alone.
Absolutely not. And the Aware Books Access, Watch, Reserve categories are really helpful too.
Oh yeah, that system is great for making sure we're using the right antibiotics for the right situations.
It helps you prioritize, use those access antibiotics for the common infections, be more careful with the watch antibiotics, and save those reserve antibiotics for the really tough cases.
Keeps everyone on the same page.
Exactly. Speaking of tough cases, let's say you have a patient who just got back from a trip to Southeast Asia, and they come in with those vague sepsis symptoms. Does that travel history change your initial approach at all?
Oh, travel history always throws a wrench in the works. It makes you think about those bugs that you might not normally see in your everyday practice.
You have to expand your horizons a bit, right?
You do. Like you might suddenly be dealing with something like melioidosis, which is caused by Burkholderia pseudomele.
And that's not something you see every day in, say, North America.
Definitely not. So it's like you have to switch your brain into a different mode. Consider those less common pathogens.
Always be prepared for the unexpected. Okay, so we've talked about choosing those initial antibiotics, but what about dosages and how long you keep someone on them? Is there like a set rule for that, or does it depend on the situation?
It totally depends. The Aware book gives some general guidelines, but you always have to tailor the dosage to the individual patient. Like, how much do they weigh? How are their kidneys doing? Right, those factors all come into play. And what about the duration of treatment?
Well, that can vary a lot too. For a simple UTI, you might only need a few days of antibiotics. But for something like sepsis coming from a nasty abdominal infection,
you might be looking at weeks of treatment.
Exactly. And those decisions are often made in collaboration with the doctors, considering how the patient's responding and all the other factors involved.
It's a team effort all the way. Well, we've covered a lot in this first part of our deep dive. We've talked about what sepsis is, how to recognize it, those crucial lab tests, and those early antibiotic choices.
It's been a whirlwind tour of sepsis basics.
But we're not done yet. In the next part, we'll delve into the nitty-gritty of how sepsis actually wreaks havoc in the body, the pathophysiology, and we'll explore the global burden of sepsis, because this is a problem that affects everyone, everywhere.
Stay tuned.
All right, so let's shift gears a bit now and really zoom in on the inner workings of sepsis.
Get down to the nuts and bolts.
Exactly. It's one thing to look at lab values and symptoms, but understanding the pathophysiology, well, that's where the real story unfolds.
I like that, the real story.
Hmm.
Because it is kind of like a battle going on inside the body, isn't it?
It absolutely is. So picture this. You get an infection, right?
Yeah.
And your body, like a well-trained army, launches this immune response.
Sent out the troops.
Exactly. White blood cells are mobilized, inflammatory mediators are released. It's all hands on deck to fight off that invader.
All systems go.
But here's the thing with sepsis. This response, which is normally so protective, goes haywire. It gets out of control.
So instead of a targeted strike, you get collateral damage.
That's a great way to put it. The immune system, in trying to neutralize the threat, starts damaging the body's own tissues and organs.
Friendly fire?
Exactly. And then things really start to spiral. Blood vessels get leaky, clots form, oxygen can't get to where it needs to go. It's a whole cascade of events that can quickly become life-threatening.
And I imagine some people are just more prone to this kind of over-the-top immune response than others, right?
Oh, absolutely. Age is a big factor. Underlying medical conditions like diabetes or HIV can make a difference too. And even genetics play a role.
So it's like some people's immune systems are just a little bit trigger happy.
Yeah, you could say that. Their alarm system goes off even when there's just a small threat. And that can make a seemingly minor infection turn into full-blown sepsis.
So you need to be extra careful with those patients, keep a close eye on them.
Absolutely. Recognizing those risk factors is a huge part of our job as microbiologists. It helps us anticipate who might be more vulnerable and act quickly if things start to go south.
Speaking of the big picture, you're passionate about the global epidemiology of sepsis. And those numbers we talked about earlier, 11 million deaths worldwide, that's just...
It's staggering, isn't it? And what's even more concerning is that the burden of sepsis isn't evenly spread across the globe.
Right. Some regions are hit much harder than others.
Exactly. And understanding those regional differences is crucial for tackling this problem effectively.
So give us a sense of those disparities. Where are the hot spots for sepsis?
Well, sub-Saharan Africa carries a particularly heavy burden. It's a complex situation, you know. There's limited access to healthcare, a higher prevalence of infectious diseases, and challenges with infection control measures.
A lot of factors working against them.
It's heartbreaking, really. And then you have maternal sepsis, which is a huge concern, especially in low and middle income countries.
Maternal sepsis? I don't think I've heard of that.
So this is when sepsis occurs during pregnancy or just after childbirth. And it can be devastating for both the mother and the baby.
Oh, wow. I can see how that would be especially dangerous.
It is. And it often comes down to a lack of quality maternal health care, which sadly is still a major issue in many parts of the world.
It's a reminder that sepsis isn't just a medical problem. It's tied to those bigger social and economic issues.
It really is. And then on top of all that, you have the looming threat of antimicrobial resistance, which just adds another layer of complexity to the whole thing.
Yeah, that's the elephant in the room, isn't it? As a microbiologist, you're right there on the front lines of that battle against resistance. How do you see those trends playing out in the context of sepsis?
It's like this constant arms race. As bacteria evolve and become more resistant to our existing antibiotics, we have to turn to newer, stronger drugs.
And those aren't always available, are they?
No, especially in resource-limited settings. And the more we use those powerful antibiotics, the more likely we are to fuel further resistance.
It's a vicious cycle. Okay, so let's get back to the lab for a moment. I know you're always on the lookout for those specific pathogens that are commonly linked to sepsis.
We are. But it's tricky because the culprit can vary so much. It depends on the source of the infection, the patient's medical history, their travel history.
It's like a microbial whodunit, huh?
Exactly. We're piecing together clues to find the mastermind behind those sepsis symptoms.
So no easy answers when it comes to pinning down those sepsis-causing pathogens.
Not really. But we can make some generalizations based on whether the infection was acquired out in the community or in a healthcare setting. Like community-acquired sepsis, you're often dealing with those usual suspects, E. coli, Staph aureus, strep pneumonia, those kinds of bugs.
Those are the ones that always seem to be causing trouble.
They're the repeat offenders, for sure.
But what about hospital-acquired sepsis? Those bugs tend to be a bit more hardcore, right?
Oh, they definitely are. Hospitals are breeding grounds for those multi-drug resistant organisms, Pseudomonas, Acinetobacter, those ESBL-producing enterobacterales. They're all major players in that setting.
So dealing with those resistant bugs must make choosing those initial antibiotics even more challenging.
It definitely does. You're constantly weighing the risks and benefits of using those broad-spectrum antibiotics, the ones that can tackle those tough bugs against the potential for fueling more resistance. And sometimes you're forced to make those tough calls before you even have the culture results back.
It's a high-stakes game, that's for sure. But we can't forget that it's not always bacteria that are causing the trouble.
Oh, that's right. We can't get too bacteria-focused. Fungi, viruses, even parasites, they can all cause sepsis too.
So we need to keep a broad differential in mind.
Absolutely. And that's where those epidemiological insights are so valuable. Knowing which pathogens are prevalent in your region, being aware of any emerging threats that helps you cast a wider net and make those critical decisions more effectively.
It's like you have to have this mental map of the microbial landscape, constantly updating it as new information comes in.
That's a great way to put it. But even with all the knowledge and tools we have, sepsis is still a formidable foe, and that's why prevention is so important.
I was just going to say that. It seems like the best way to win this fight is to stop it from happening in the first place.
Absolutely. And one of the most powerful weapons we have in our arsenal for preventing sepsis is vaccination.
Good old vaccines.
Yep. Like the pneumococcal vaccine can help protect against strep pneumonia, which is a big cause of pneumonia and sepsis. And the meningococcal vaccines target Neisseria meningititis, which can lead to meningitis and sepsis.
Those childhood vaccines really do make a difference. And even for adults, staying up to date on their vaccines is important.
Absolutely. But it's not just about vaccines. Those basic hygiene practices that we all know, washing our hands frequently, covering our coughs and sneezes.
Common sense stuff?
Exactly. Those things play a huge role in preventing the spread of infection. And when you think about those regions where access to clean water and sanitation is limited, well, those basic public health measures can make a world of difference in preventing those infections that can lead to sepsis.
It's all interconnected, isn't it? Individual actions, those bigger public health efforts, that global perspective. It all feeds into how we approach this fight against sepsis.
Well, we've covered a lot of ground in this part, from that microscopic view of the pathophysiology to the global burden of sepsis and that whole cast of characters, the bacteria, the fungi, the viruses, even those parasites that can be involved.
A real deep dive into the world of sepsis.
It has been. And now, I think it's time to put our knowledge to the test.
I'm game. Let's see what you've got.
All right, first question. What is the hallmark of the Sepsis 3 definition, the thing that really sets it apart from those older definitions?
Oh, this one's easy. It's the focus on organ dysfunction. The Sepsis 3 definition recognizes that it's not just about the infection itself, it's about the body's response to that infection and how that response can lead to organ damage. That's exactly right. It's not just about finding the bug, it's about understanding how the body's reacting to it. Okay, next one. You have a patient who you suspect might have sepsis, but their inflammatory markers, their CRP and procalcitonin, are normal. What's your next move?
This is where you have to trust your gut. Those lab values are helpful, but they're not the whole story. If the patient has other signs of sepsis, like altered mental status, low blood pressure, or trouble breathing, I wouldn't hesitate to start treatment, even if those inflammatory markers aren't screaming sepsis.
You got to read between the lines sometimes.
Exactly. Don't ignore those clinical red flags. All right, question 3. A patient comes in with fever, chills, and a cough after a trip to Southeast Asia. What's a bug that should be on your radar, even if it's not something you see every day in your region? This is where that travel history becomes so important. I'd be thinking about Burkholderia pseudomale, the culprit behind melioidosis. It's endemic in Southeast Asia, and it can definitely cause those kinds of symptoms.
That's a good one to remember. Travel history can really broaden that differential diagnosis. Okay, 2 more to go. This one's about those tricky antibiotic choices. You suspect an ESBL-producing organism in a patient with sepsis, but the culture results are still pending. How do you approach those initial antibiotic decisions?
This is where the AWARE book and those local resistance patterns are your best friends. Knowing that ESBLs are a concern, I'd probably start with a carbapenem. It's a watch antibiotic, so you want to use it carefully, but it offers good coverage against those resistant bugs.
So striking that balance between being aggressive and being responsible with those antibiotics.
That's the name of the game. Okay, last question. What's a simple everyday thing that everyone can do to reduce their risk of sepsis? This one's a no-brainer, wash your hands. It sounds so basic, but it's honestly one of the most powerful ways to prevent the spread of infection.
Can't argue with that. Good old-fashioned hand hygiene. Well, it seems like we aced that exam.
We did pretty well, I'd say. It's amazing how much we've learned about sepsis in just a short amount of time.
It's been a wild ride. And we're back for the final part of our sepsis deep dive. We've really gone deep on this one, haven't we? From those first subtle hints that something's off, to the lab's role in finding the culprit, and all those tough decisions about treatment.
It's been a pretty comprehensive journey, and as we wrap things up, I think it's worth taking a moment to reflect on what all this means for you as a medical microbiologist out there on the front lines.
Yeah, let's bring it all home. So, what are the big takeaways? What are the things that every microbiologist needs to have in their mental toolkit when facing sepsis?
Well, first and foremost, we can't forget that sepsis is a real killer, and time is not on our side. Those early interventions, they can be the difference between life and death, so we have to be really sharp picking up on those subtle signs and symptoms.
Even when they don't scream classic sepsis.
Exactly. Sometimes those textbook presentations, they're not always what you see in real life. So trust your gut. If something feels off, dig deeper.
Don't dismiss those nagging doubts.
That's right. And tools like the QSO-FAFIS score, those can be really helpful for triaging patients, especially in those early stages.
Helps you figure out who needs that extra attention right away.
Exactly. Then, of course, there's the lab's role, which is all about identifying that culprit.
Blood cultures, sputum, urine. We're always on the hunt for that bug.
But it's not just about finding the bug, right? We need those other lab results, too. The creatinine, the bilirubin, the inflammatory markers, all those pieces give us a more complete picture of what's happening.
It's like we're putting together a giant puzzle. Each lab result is a clue.
That's a great analogy. And then there's the treatment side of things. We know antibiotics are key for sepsis, but choosing the right ones, especially with resistance on the rise.
That can feel like navigating a minefield.
It can. You want to be aggressive, but you also have to be smart. You don't want to contribute to the resistance problem.
It's about finding that balance, using those antibiotics judiciously. And that's where resources like the Aware book really come in handy.
Oh, absolutely. It helps you prioritize, make those informed choices. But beyond treatment, we also need to be thinking about prevention.
Because the best way to deal with sepsis is to stop it from happening in the first place.
Exactly. And vaccines, those are a huge part of that.
Making sure people are up to date on their shots.
Yep. And the basic stuff, good hygiene practices.
Hand washing, covering your cough.
All of those things that we sometimes take for granted, they can really make a difference. And those bigger public health efforts, especially access to clean water and sanitation, those are crucial too.
It really does take a village to fight sepsis, doesn't it?
It does. Individual actions, public health measures, that global perspective, it's all connected. So I think if there's one thing for microbiologists to remember, it's that sepsis is constantly changing. We have to stay up to date, learn from the latest research and guidelines, be aware of those resistance patterns. That's how we'll stay ahead of this challenge.
Always be learning, always adapting.
Exactly. And remember, you're not alone in this fight. We're all in this together.
Teamwork makes the dream work, right? Well, as we wrap up this deep dive, I want to leave you with this thought. The fight against sepsis, it's a long game. It takes persistence, dedication, and a willingness to keep learning and growing.
And never give up hope. We can make a difference. One patient, one test, one decision at a time.
Well said. Thanks for joining us on this incredible journey. We hope this deep dive has given you some new insights and tools to tackle sepsis head on. Keep those minds sharp, keep learning, and keep fighting the good fight. Until next time, stay curious.